Hi, everyone. This is Linda Rowe. I'm Senior Advisor of Value-Based Markets at InterSystems. I was recently at the RISE event in Colorado Springs, and I had the pleasure of moderating a session with Kate Beck and Autumn Kerr from Health First, a health plan based in the New York City region. If you couldn't join us, please listen in on this session and learn more about how they have used event notifications to improve their quality measure reporting.
Thank you, everyone, for rejoining us, and thank you so much for your attendance at RISE on behalf of RISE. I'm honored to be the track moderator for our final track today, focused on population health and SDOH and health equity. My name is Evelyn Chinaki. I lead the health plan strategy for SWORD Health. SWORD is a virtual physical therapy company really focused on extending care to members where they are and where they want to receive it in the most convenient and most accessible way. Today's session is titled Clinical Data plus Proactive Notification equals Improved Quality Measures and Performance. And to moderate the session, I'm going to turn it over to Linda Rowe, Senior Advisor, Value-Based Markets with InterSystems. Linda, the mic's yours.
Great, thanks. Thank you for all of you who have stayed this afternoon. We really appreciate that. So I work for InterSystems, and I look at the intersection of payer-provider collaboration, and certainly quality measures involves both working with payers and providers collecting that information. But it's really Kate and Autumn that I want to introduce because it's their story we're going to tell. So Kate?
Hi, good afternoon, everyone. Sorry, I'm not used to speaking on a mic. But my name's Kate Beck. I'm the AVP for the Health Information Exchange at Health First. We have a private HIE. And I work very closely with Autumn in clinical quality.
Hi, everyone. Autumn Kerr, AVP Clinical Quality. I work on HEDIS and our quality streams, and I do a lot of provider engagement in support of HEDIS. Thank you.
Great. So really quickly, I'm going to talk about incorporating clinical data into quality measurement. And then I'm going to turn it over to Kate and Autumn to tell about their journey with quality measurement and clinical data. And then I'm going to have a moderated conversation with them, and then I will turn it over to the audience for Q&A if you have questions. So thinking about quality and performance measurement. So first and foremost, the shift to value-based care has really placed an emphasis on provider performance and outcomes versus sort of process and outputs. And programmatically, quality measurement continues to be a priority for health plans. Certainly the health plans we work with and talk to are always talking to us about their quality measure program. But the measures are continuously changing. Sort of every year there are a new set of specifications. NCQA comes out with new measure sets. CMS issues new rulings. But the interesting thing that I always think about is quality measurement is sort of two sides, right? There's measuring the performance, but then there's making sure that your membership or your patients are actually getting the right care, and that's closing those gaps in care. And for me, they're two sides of the coin, right? Because you can't improve performance of your plan if you're not improving access to care and getting your patients in for care, your members in for care, to be able to improve that performance. So what you don't know, you can't measure. And if you think about NCQA, they have been on a journey for quite some time. I've been following it. They've started to have their digital measure quality summits where they talk about this movement, but they're really trying to incorporate and figure out how do we move away from chart retrieval, chart chase, to moving towards getting clinical data as the basis of quality measures. And so their journey is about flexibility in measurement, accuracy, making sure you're getting better information because often you're not getting everything in the claim, making it easy with the digital measures, insight through the ECDS reporting. We'll talk a bit about that during the Q&A. And then sort of timeliness, right? You can be more timely when you're actually getting access to that clinical information and then finally having access. And they've been on their journey, and many of you have probably been on that journey with them as they've been moving along over the last measurement years, measurement cycles. So if you think about part of their digital data measures roadmap, they want to reduce the reporting burden by getting the data they need from the provider EHRs directly and have that embedded in their workflow. And then there needs to be greater flexibility to allow adjustments to some of the measure specifications to meet state, local, or system needs, right? Because I certainly, in one of the hats I wear, I sit on the board of a federally qualified health center. And one day I went to our CMO and I said, how many measurement programs are we participating in? And the list was very long and the overlap was very small, which meant that, and it didn't mean you weren't measuring the same measure. There were a lot of diabetic measures, but the technical specification on how you had to calculate that measure was slightly different. And so I know that CMS and NCQA are trying to figure out how do they make that easier for both provider organizations and then subsequently the health plans who have to report on those. And then they're building the foundation for new outcome-based measures, right? A lot of the measures that we've seen historically have been process measures, measured by claims. You know, did I have a mammogram? Was a colonoscopy done? Rather than looking at outcome measures, which really you can't look at deeply until you start looking into the chart. So that's sort of part of their journey. So before I talk about the roadmap, I want to just talk about sort of digital measure packages, because if you haven't, you're not familiar with the terminology. So there's the QDM, the quality data model, and that's really the elements that are needed for measures, and they're often used on the provider side for electronic clinical quality measures for MIPS or promoting interoperability. So those have been long-standing measures. They were developed over time as part of the Meaningful Use and Now Promoting Interoperability program for providers to report to CMS as part of some of their programs. And then FHIR, F-H-I-R, is a transport mechanism and a data model. It's both. So it's a way of sharing clinical or other information, and then a data model for being able to actually store and exchange that information. And then the clinical quality language is sort of the heavy lifting that actually uses those other two things, the data model and FHIR, to create the measure computation. And it was very interesting when I talk a little bit about the journey of the Da Vinci project, and I'll explain that. One of the things was the development of this sort of CQL measures and where they were at in their journey when we were trying to implement that. So again, sort of there's this journey as well going on around quality measure reporting. So, you know, hybrid measures, obviously you all know, require that clinical data. And so started with the access to the EHR chart, non-standard sup data, and then moving to standard supplemental data, right? So the data aggregator validation program is something NCQA has started with health information exchanges, public HIEs. I want to make that distinction, where they are certifying data streams so that payers can actually use those data streams for standard supplemental data. And then there's the ECDS program. So again, limited number of measures reportable now, but they keep expanding every year what those are. They don't replace the supplemental data, but they can be used instead for certain measures. And there are a lot of different sources, EHRs, HIEs, registries, even case management systems can be a source. And they use that CQL to define the measure specification. So the Da Vinci project is interesting, and if you're not familiar with it, it is a national effort to improve payer-provider collaboration using FHIR as the standard to move data between payers and providers to solve for value-based care use cases. And those have been built out over a number of years. We've been going at it for about 4 years. But the Data Exchange for Quality Measure program was really exchanging data between payers and providers using FHIR and using CQL. And when we did this pilot with one of our customers, they actually hadn't gotten to the point where they translated some of the measures into the FHIR-based CQL specification. And so we had to pick what measures we did with the pilot based on what actually existed, not based on sort of what made sense at the time, because there were other more higher priority measures. And then, there's sort of the FHIR-based e-measure program that NCQA is just starting to launch. And again, it's predicated and based on this, the ECQMs that are being built out. So I think this is just, an illustration of how you can think about those two sides of the coin. So if you look at the top purple line there, that's sort of the total population. And then what you're seeing in red are the population that's out of compliance, in other words, A1C over 9. The sort of greenish blue boxes are actually those where we don't have an activity within the window. So those are gaps in care. And so that's the kind of information where you could click and find out, all right, who's my membership that have a gap in care, and how do I then route those to the right provider to have them help close the gap in care? And they're going to talk a lot about how they're using information to do that. So notifications, again, using ADTs, admission, discharge, transfer notifications are often the way that comes into a health information exchange. So the benefit of a notification is it's near real time. You get that almost immediately upon an event. And as many of you know, there's some measures that by the time you get the claim, it's too late to close the gap. You just don't have that window. So the example I have here is, the trigger event being a woman who's fallen, had a fracture, ends up as an inpatient, and then there's the osteo measure. Well, claims post-inpatient discharge or ED discharge might not get the information to the right person. So maybe the plan knows about it, but then the care manager doesn't get to the provider, and by the time they figure out that that follow-up visit should have happened, it hasn't. And you've completely missed that window. And there are other measures that Kate and Autumn are going to talk about that have even shorter action times and the way they're solving for that. So at this point, I'm going to turn it over to Autumn, who's going to tell you a little bit about their journey together with Kate.
Yeah. Thanks, Linda. So I just want to introduce Health First, who we are, what we do. So Health First is the largest not-for-profit health insurance company in New York State. We were founded about 30 years ago by some of the biggest healthcare systems in New York. What we do is we work in conjunction with all of these healthcare systems and our community providers to improve the health outcomes and the health equity of our members. And we do this in part by aligning financial and quality incentives. And we also share that timely and actionable data, which is what we're really here today to talk about. So we do have about 1.9 million members, and this equates to roughly 1 in 4 New York City residents is a Health First member. The majority of our membership is located in New York City, but we do also have membership out on Long Island and up the Hudson Valley. We have 15 sponsor hospitals. We have 80 plus participating hospitals and over 20,000 doctors and specialists located at 40,000 locations. So that's Health First, that's who we are. I'm now going to pass it over to Kate, and she's going to go through the evolution of our private health information exchange and talk a little bit about how it has informed HEDIS and clinical quality.
Thanks, Autumn. All right, so let's talk about the Health First HIE. So the first thing I wanted to share about our HIE is that we're a private health information exchange. So we are funded by Health First as opposed to public health information exchanges that are generally funded by states or departments of health. And back in 2015, Health First made the decision to invest in a private HIE simply to promote the sharing of data between our providers and Health First in support of our members and in support of care coordination. And the vision that we had for our health information exchange was really a bidirectional exchange of data, where our provider network would send to us visit and clinical information that we would then use for care management and clinical quality activities. And in return, Health First would share back information to the providers, such as claims data, care gap data, pharmacy fill data, and the providers would use that information to help coordinate care and identify any missing services. And so in 2015, we stood up our HIE platform. We use HealthShare, and we connected our very first connection, which was one of our sponsor organizations. And then over the years, we've continued to grow those interfaces. So to date, we have 280 interfaces feeding data into our HIE. It does represent data from about 700 to 800 practices, depending on how you count it. We get about 700 visits a month, 1.5 million lab results, And we have current data on roughly 80% of our 1.9 million members. And we define current data as activity in the last 12 months. So that's a little bit of information about our HIE. We do have a lot of data in there, and we actually use that information to support a number of use cases across Health First, but by far, clinical quality is the largest. And so if you look at this timeline, you can see, so we stood up the HIE in 2015. So by 2018, we had actually connected to the majority of our sponsor organizations. And we also felt mature enough as a program, and we had enough confidence in the quality of the data that we had coming into the HIE that we felt like we could finally use that information to support clinical quality. All right, so I'm going to talk a little bit about the 2 use cases where we support clinical quality. But before I do, I just want to give a quick overview of our HIE. So you can see that the organizations on the left really represent the full spectrum of provider types feeding data into our HIE. So it does start at the acute level, so we get information from inpatient and ED facilities, subacute or post-acute facilities, ambulatory organizations. We are connected to some ancillary providers to get lab results and radiology results. We are connected to the New York City Department of Health, and specifically the immunization registry. And then there in the bottom right, we are connected to one of the public health information exchanges in New York State. There are 6. HealthX is the biggest one in the downstate region, and they actually represent about 25% of our ED and inpatient visits that we get notified on. And then you can see all of those different organization types are feeding data into our HIE in what we say is near real time. So for us, that means that the HIE is notified of specific events generally within 1 to 24 hours of those services being provided to our members. And so all of that data is fed into our HIE platform, which, like I said, is HealthShare. The platform is actually far more complex than I've indicated here, but for this particular use case, you can really think of it as a data repository. And we are a centralized HIE, meaning that we are pushed, or we either pull information into our HIE, and then it resides there sort of indefinitely. We never purge any information. All right, so the first use case for clinical quality that we decided to support was, this is what I call our more passive approach. So this is capturing clinical activity. And this is where we're really using data in the HIE that indicates a service has already been provided, and we can use that information to actually close the care gap. And so a lot of this information is ultimately going to be provided through claims, but because the HIE is getting notification of this information generally within 24 hours of it being provided, we're able to close care gaps much more quickly. And that allows our provider network and our internal care managers to really just focus on closing the care gaps for those members that still have open services. So we first started supporting this particular use case back in 2018. We started with 1 measure, and over the years we've added additional measures. So today we support 18 to 20 different measures, and we're able to use HIE data on a monthly basis to close those. Now the second use case we have, we kicked this one off in 2020, and this is the one we're actually going to talk about today. And this is our more proactive approach, and we reference it as guiding clinical care. And this is where we're using HIE activity to identify members who have had very specific activity that will likely put them in the denominator for a specific measure. And then we use that information and we share it with our provider network so that they can do the necessary follow-up steps that will ultimately make that member compliant. All right, so this is our notification process. So the HIE team works very closely with Autumn's team to identify the specific criteria or triggers for the different measures. And the criteria is different for the different measures that we support. And what we do is we basically identify that criteria, we develop a query, we run it on a nightly basis to identify and pick up any of those qualifying events. And then we take any of those members that have those qualifying events and we identify the appropriate provider that we want to communicate that to. And it does depend on the measure. Sometimes we send that information to the servicing or the discharging facility. Sometimes we send it to the member's PCP, or sometimes we even send it to the health home. And so once we have those qualifying events, we know who we're going to send it to. We bundle all that information up in a secure email. We send it encrypted because it does contain PHI. And then we mail it out. And this happens 5 days a week, basically. So I have given a sample of what that email looks like. It's pretty simple. It's just an email with an Excel spreadsheet attachment. And then our expectation is that when those providers get those emails, they're going to engage the member, they're going to perform any of those necessary follow-up activities that are specific to the measure we're trying to address, and then ultimately those services will come back to Health First in the form of a claim. So I'm going to turn it over to Autumn, who's going to talk about the specific measures that we designed this for.
All right, so what measures are we actually using this for? I'm going to go through 3 today. This is not all of them, but it's the 3 we wanted to talk about today. So the first one being follow-up after ED visit for members with mental illness. So the triggering event for this is a emergency department visit with a behavioral health diagnosis. So that's the triggering event. The alert gets sent back to that discharging facility, and we're asking that those providers have the member return to care within that 7-day window. The next measure, transitions of care, and we focus on the medication reconciliation post-discharge submeasure. The trigger is that inpatient diagnosis, so the alert that goes out to the servicing provider and the PCP in this case does have that discharge date with the request that they bring that member back in for that med rec within 30 days. And then our third measure for today is follow-up after ED visit for substance use disorder. And much like FUM, right, the triggering event is an ED discharge with an SUD diagnosis, and we're asking that these members return to care within that 7-day window. So why are we looking at these 3 measures in particular? The simple answer is, as Linda mentioned, a claim is useless in this case. By the time the claim drops and we get it, it's been adjudicated, it's probably, I would say 90 to 120 days past, and any information going back to the provider is, it's too late. So our HIE was the obvious choice to be able to get that data back to these providers to support them in order to get them, the members back in for care. So as Kate and Linda mentioned, the HIE receives these alerts in near real time through the ADT process, and enables us to give our providers as much time as possible within that short 7 to 30-day window. And then finally, we have a pretty intensive incentive program, which these 3 measures are all a part of. So we don't want to keep our providers on the hook and say, we'll give you an incentive if you close this, but we're not going to give you any supporting documentation. So these reports go out every weekday, and we're going to go to the next slide and talk about the success we've seen. So the first measure, FUM. So we did an analysis and we conducted the alerts that were sent out between August and October in 2022. So for FUM specifically, we saw a 3% increase in compliance. So it was 40 versus 37% of emailed versus non-emailed events, which at first we were a little hesitant about. We're like, only 3%? But once we drilled down into the data, we saw that some of our hospitals had between 10 and 20% increase in compliance. So we thought, okay, let's take that opportunity to figure out what those hospitals are doing in particular, get their best practices, their workflows, and we'll be sharing that with other hospitals in order to have every hospital get to that same increase in their rate. So for TRC, MedRec, we saw a 5% increase in compliance, 35 versus 30. This was the first report we sent out back in 2020. So we do have a little bit additional analysis. We did want to keep the snapshot for this in particular, but throughout the year we see a 5 to 10% increase in this measure. So we know that these reports work in the long term, so we're excited about that. And then finally, FUA. FUA, we saw a 9% increase in compliance, and we were thrilled when we saw this. This measure in New York State, there's really strict privacy laws around sharing SUD diagnoses back with anyone other than the provider that diagnosed that member with SUD. So it's very hard for us to give any information to PCPs, behavioral health providers. We can only go back to that servicing or discharging provider where the member was in the ED. So when we saw that we had a 9% increase, we were excited because we finally found a way to be able to get these members back in for care, right, to avoid the ED visit. So ultimately, what are we trying to accomplish? We don't want members going back to the ED. We don't want them being readmitted. And we're seeing with these, with our analysis, that this is working. And as Kate is going to go through some next steps, but we're really excited with what we saw. And I'll let Kate go through what our next part is.
Can you hear me? Okay, there we go. So process improvements. So this is a very early, sort of early on process in terms of its maturity. And I think, as Autumn said, not to be repetitive, but we are extremely excited about the impact that we saw, given that this is really our first iteration of the program. So some of the things that we have identified, though, are that some of those measures that are diagnosis specific, so FUM and FUA, what we found in the HIE data is that diagnosis tends to trickle in. It trickles in while the member or the patient is admitted, but it also trickles in even after the member has been discharged. And when we took a look at our data, we found that we actually saw a 50% increase in diagnosis data coming in up to 72 hours post-discharge. And so we're actually changing our queries to incorporate that 72-hour look back. And as a result, we're going to identify even more qualifying events for those particular measures, which is FUM and FUA. And then the second process improvement, Autumn touched on this a little bit, but we did see some hospitals who did outperform some of the other hospitals with a 10 to 20% increase in compliance as a result of these emails. So again, we just want to reach back out to them, really see how they were able to incorporate these emails into their workflow, and then share some of those best practices with some of the lower performing hospitals. And then in terms of program expansion, we do want to roll out the alerts to all of our providers that participate in our quality incentive program. So in this initial stage, we weren't emailing every provider. It does take there's some participation agreements, some paperwork, basically, as legal likes to say. They like to paper the participation. So we need to get additional practices set up with that. And then once we do, we're going to roll that into our process. And then secondly, we have already identified 4 additional measures that we intend to roll out with this program throughout this year. So with that, I'm going to turn it back over to Linda.
Great, thanks. So thanks to our Day 2 warriors for being here. So I'm going to turn this and ask a question of you. How many of you are using CCDAs and ADT alerts and clinical data to drive your quality measure program? I see a few hands. How many have been doing it for more than a year? A few. How many have been doing it more than 3 years? So it's still pretty new, but the folks at Health First have really been pioneers in using this data to drive their quality program, and so it's very exciting. So I'm going to act as a moderator and ask them some follow-on questions, because that's always fun. So the first question, and I can go with both of you, what are some of the challenges with using HIE data to drive your quality measure program? And I don't know who wants to go first, but I know you both have opinions.
Yes, I'll take that one. So I would say one of the biggest challenges we have in HIE is really around data quality. So I had mentioned, we have 280 interfaces, roughly 800 practices. And so when you think about that's 800 practices, each with a specific workflow that they have, they're all documenting data in a variety of different EMR platforms. And then those EMR vendors actually map data points to the interoperability standards, which are the HL7, the ADTs, the CCDs. They all map them slightly different. And so as a result, we have a lot of data variance in our HIE. It's not that the data is incorrect, it's just recorded slightly differently. And it can make it difficult to use at a big scale. And so we spend a lot of time analyzing the data, trying to understand what we're getting in our data set, and then normalizing and standardizing it where we can. I think a second challenge we have, and it's really an opportunity, I would say, is learning how to leverage the unstructured data that we get in the HIE. So we get about 50,000 discharge messages, unstructured notes, every month in the HIE. And at the moment, we have not really been able to tap into that for clinical quality. We do share it with our care managers for care transitions. But for clinical quality, because it's not structured or codified, it's been challenging to use. So we are working with our data science team internally to develop NLP capabilities, natural language processing capabilities, to scan through those 50,000 documents and identify potential hits for different measures.
So great. Autumn, maybe you can talk a little bit about how you're planning to continue to expand your quality measurement program, because I know sort of every year you intentionally think about what new measures are going to get added into the repertoire, and also better ways that you're going to communicate it with your provider network.
Yeah, so we're always looking for process improvement, continuous quality improvement. And like Kate said, increasing the number of measures that we are sending out in these alerts. We're adding more behavioral health measures and more Medicaid measures, and they're all ED and hospital based. So being able to provide that timely actionable data back to providers is our main focus. I think everyone on my team is sick of me saying it. How are we helping our providers? I have a team, about 17, that's in the field and actually working one-on-one with providers, with our hospitals, community-based providers, and we're asking them, how can we help you? And they say to us, we need data. We need to know who's coming out of the hospital. Can you help us? So this is what we're doing to really get them. And we're really fortunate that we have HIE data to send back to them, because we know not every health plan is as fortunate as us. So as we get the feedback from our hospitals and providers, I go back to Kate and I say, Kate, what can you do for me? And then she says, give me a month, Autumn, I got you. So we're really, being able to expand that is really great. And I know next month I'll go to Kate again and I say, this is what we're going to need, and she's going to be there.
I just want to thank Kate and Autumn from Health First for speaking here today. I hope you enjoyed our discussion. If you have any questions, please check us out on our website, www.intersystems.com, or drop me an email at linda, Lynda.rowe, ROWE, @intersystems.com. Thanks for joining us.